Orthopedics, all about back pain. Back pain is a common problem in our community. We usually refer to it as low back pain. Doctors don't like treating it because it's so common and so frustrating to get a good result. There are a lot of other people who get involved in treatment, such as osteopaths and chiropractors, but as a doctor you'll often see back pain, and it can become quite confusing and frustrating to treat. But there's a few things you need to be aware of, and you need to be able to exclude in your management of such pain so you don't make any big mistakes. First of all, you've got to make sure you don't miss a fracture, a tumour or infection in the spine. This would be a disaster and cause a lot of problems for you and of course for the patient. A very simple way to exclude this is to tap the spine with your fist going down the spine. It's not that hard. If the patient's in a lot of pain, then you can suspect it's one of these three things which you don't want to miss before you start calling common variety discogenic or degenerative spine. Again, fracture through the x-ray, tumour, the x-ray, most likely metastasis, the patient will also have night pain, and infection, the patient will be unwell. Here they are illustrated, a fracture, L5 crush fracture. Here's a CT, but it will be evident on the x-ray. A tumour, you don't want to miss it. Here's a lung cancer patient who presented low back pain for 3 weeks, 68-year-old. Here he has hot bone scan. Here's an infection, discitis, infection in the disc space in a young child. L2 osteomyelitis, 3 weeks low back pain, Staph aureus. It was in the vertebral body. So here's 3 other things you've got to be very aware of, 3 very careful things to exclude. Children with back pain, investigate thoroughly, take seriously. It could be the first presentation of, as I've said, infection or a primary bone tumour. Take it there seriously, don't dismiss it out of hand. Referred pain, don't forget, pain in the back may come from an infection in the kidney system, may be visceral, vascular. Here's one, a triple abdominal aortic aneurysm. Look at the calcification of the aorta, presenting as back pain. Don't want to miss this. Psychogenic. Be very careful calling back pain psychogenic. I know that a lot of low back pain has secondary gain, compensation issues, a way that sometimes patients use to manipulate the workplace or their spouse. Wardle signs, you can look that up. You basically press down on the patient's head and they scream out in back pain. You've got to look out to see whether in fact this is genuine low back pain. Okay, we've excluded those 3 things. Now we get on to the common variety discogenic back pain. Herniated nucleus pulposus. 60% of the population have pain related to this. It's related to the upright posture. It's discogenic. The disc spaces between the vertebral bodies dry out with time, narrow, rupture, and later arthritis forms in the spine and the small joints behind it called the facet joints. These discs can bulge, rupture or extrude, separate or sequester. Here's one that's ruptured, going right out, putting pressure on the nerve root in that area. That will cause pain in the back. Pressure on the nerve root will cause pain down the leg. That's called sciatica. How to treat it? Brief rest. If you put them off work for too long, they'll never get back to work, and that can be a disaster. Pain relief, weight loss, a fitness program, very important. Injections of steroids, maybe. Physiotherapy and manipulation, maybe. Occasionally surgery. Surgery, yes, if with a herniated nucleus pulposus, they have the following: quarter equina, very serious, foot drop, can't dorsiflex the foot, urinary incontinence, dry panties, it's a very worrisome sign or finding, constipation, loose motions, with perianal or saddle anesthesia. This is a major rupture of the disc. Here it is, a major rupture of the disc with pressure on these essential nerve roots, sacral nerve roots. This is a potential disaster. You need to have an emergency decompression. Okay, some other aspects of HNP. You need to know about claudication and pseudoclaudication. Pseudoclaudication is from spinal stenosis. The canal narrows because the arthritis associated with loss of disc space height. However, the difference from claudication, which is vascular, pseudoclaudication, which is neurogenic, is that in pseudoclaudication there's a pulse because it's not related to the vascular system. Pain, numbness and weakness with exercise. You see these patients leaning forward on the supermarket trolley to ease it in the supermarket, whereas a vascular one, no leg pulses because the arteries are diseased. The pain is distal and it's worse, or heavy pressure in the calf with exercise. Remember to distinguish the two. Basically the pulses. Spinal instability. This is with a HNP. Patients report a catching sensation with transfer activities, getting in and out of bed, in and out of chairs. The spine seems to be unstable or catching. Here's a patient with spondylolisthesis, asymmetric lumbar or loin creases. And here's a slip, L4 on 5. Little pars defect, little fracture in the back. The posterior elements are defective. The vertebral body slip forward. Can be pain, even in a young patient, 21. They may need stabilization procedure. Sometimes the vertebral body slip right off. Here it is, L5 slip right off on the sacrum. So I hope you find this useful. To reiterate, with low back pain, don't dismiss it out of hand. Exclude fracture, infection and tumour by tapping the spine. Do basic investigations such as an X-ray. Then go on and treat it as a discogenic. Don't always say it's psychogenic. I've outlined how to treat the discogenic, and I've also outlined how to look out for cauda equina and also how to manage pseudoclaudication and spinal instability. Thanks for your interest.